Introduction to Psychiatric Pharmacotherapy. Basics and History. Script and Editing by G.S. Shankar, PharmD, PsyD, Professor of Clinical Psychopharmacology, School of Pharmacy, American University of Health Sciences, Signal Hills, California. Learning objectives. Learn the historical development of rational psychiatric pharmacotherapy. Describe the goals of pharmacotherapy in psychiatry. Define compliance and various reasons for non-compliance. Understand the importance of medication counseling in psychiatry. A brief history of psychopharmacology, psychiatric drug therapy. A drug is an exogenous chemical that affects one or more biological processes. Why learn about psychiatric pharmacotherapy? Because in the United States, most mental health services are provided by non-physician clinicians. Likewise, many prescriptions for psychotropic medications are written by family practice and primary care physicians. Consequently, it has become increasingly important for all health practitioners to have a basic understanding of psychiatric medication treatments. Influence of DSM-5 in psychopharmacology. Basic principles. DSM-5 employs a descriptive, symptom-based approach to the diagnosis of mental illness. Defining disorders consistently allows for better prediction of prognosis and treatment response. DSM-5 classifies disorders, not individuals. The medical model identifies pathology and attempts to fix it. The goals of medication management include the treatment of acute disorder, preventing relapses after improvement, and preventing future episodes. Alcohol has been nearly universal in use and was already presenting itself as a problem among ancient Greeks and Romans. There are records of cannabis use in the East, particularly in Asia and the Middle East. Opium was known to the ancients but seems restricted to medicinal use. An extract of the nightshade or belladonna plant called atropine, an anticholinergic, was used everywhere from ancient Rome to China as a poison and as a cosmetic device. In Rome, women sometimes used to put a drop of weak solution in their eyes to dilate their pupils. Drug development treatment for psychiatric issues. In 1845, hashish was used. By 1875, cocaine came into the picture. Then in 1892, it was morphine, alcohol, and ether. In 1903, barbiturates were introduced. 1927 saw the use of insulin shock therapy. In 1936, frontal lobotomies were performed. Electroconvulsive therapy, or ECT, was introduced in 1938. Lithium was introduced in 1949. By 1950, chlorpromazine, also known as thorazine, was available. The 1950s also saw the introduction of tricyclics and mayos. Finally, in the 1990s, SSRIs, SNRIs, and atypical antipsychotics became prevalent. Treatment of schizophrenia at the dawn of the 18th century was a period of trial and error, especially in the 1920s and 30s. The physiopathology of schizophrenia was not understood. Some of the treatments included the prescription of cocaine, castor oil, manganese, and injections of sulfur and even turpentine. Some patients had partial remissions with these injections. According to Croce, G. in his March 1932 publication, pyrototherapy of schizophrenia in the initial stages involved injections. By the 1930s, the understanding of fever and mental disease in 1917 led to insulin shock therapy in 1927. Chemical convulsions and schizophrenia were studied in 1934, and electroconvulsive shock therapy was introduced in 1937. Antipsychotic psychopharmacology marked the first-time elimination of psychotic symptoms rather than just altering body status. Chlorpromazine was introduced on January 19, 1952. Within a decade, 20 phenothiazines were in development, ranging from chlorpromazine to trifluoperazine to fluphenazine. Rauwolfia serpentina, or rezapine, saw its first paper on its use in 1954 by Nathan Klein. However, it quickly fell from favor, although it is still used in refractory psychosis. Haloperidol, the parent substance of butyraphenone antipsychotics, was synthesized on February 15, 1958. Due to its similarity in action with chlorpromazine, psychopharmacological research proceeded rapidly, resulting in the development of 13 products by 1990, of which haloperidol and droperidol are clinically useful. Some second-generation or atypical antipsychotics include clozapine, introduced in the 1980s in the USA, risperidone in the early 1990s, olanzapine in the late 1990s, quetiapine, also in the late 1990s, ziprasidone in 2001, aripiprazole in 2002, paliperidone in 2007, asenapine in 2011, iloperidone in 2011, and lurasidone in 2012. Compliance is defined as adherence to the recommended treatment plan of a healthcare professional. Strategies to increase compliance include encouraging active patient participation, adequate communication, an empathetic approach, and a trusting relationship. Family and community involvement and support are also crucial, as is emphasizing the positive effects of medication and using the most simplified drug regimen. Families of many consumers with psychotic symptoms are often not satisfied with their symptom improvement, regardless of how effective their medications may be. Unfortunately, most families do not accept the fact that medication may reduce but not eliminate psychotic symptoms in this specific population. This frustration quickly leads to discontinuation of medication, exposing the patient to a higher risk of relapse. Realistic goals need to be set regarding the management of their symptoms with antipsychotic drug therapy. Various reasons for non-compliance include the stigma of the disorder, denial of illness, disruption of cognitive processes, side effects of medication, slow onset of beneficial effects, and cost. While counseling about adverse effects involves discussing the negative aspects of drug therapy, the focus should be on minimizing the family's concern. When patients experience an adverse effect, they may choose the practical solution of discontinuing drug therapy. The adverse impact will usually resolve once drug therapy is stopped, but so will the drug's beneficial effects. Counseling must include discussing the typical expected adverse effects and what to do if one occurs. Families must understand that adverse effects can be treated or minimized while drug therapy continues. Clinical characteristics to suggest pharmacological treatment include psychiatric symptoms such as sleep or appetite disturbance, fatigue, panic attacks, ritualistic behavior, cognitive symptoms, and psychosis, such as delusions or hallucinations. A crucial point in medication counseling is to avoid assuming a particular diagnosis when a patient receives psychotropic medications. The use of certain medications does not necessarily agree with FDA-approved indications, certainly not in developmental disability clientele. It is important to ask open-ended questions like, "What did your physician tell you the medication is for? Thank you for your attention."